Can you move forward with this slide, please? That is my disclosure slide. So what we're discussing here is really infected fields, and it's very important to differentiate infected field versus contaminated or potentially contaminated fields. Infected fields are truly infected where you have a soft tissue infection. You may have pus, an abscess, cellulitis that's deep. Sometimes you have a bowel perforation with peritonitis, whereas in contaminated fields, it could be in the face of a colostomy, a known fistula that's controlled. Strangulated hernias would still be a contaminated or potentially contaminated area, or an open abdomen. Well, today, dealing with an infected field, as you've heard through some of these talks, once you reduce the bacterial load at the level of the wound, you may be able to either primarily close the wound with a non-mesh repair, or if you cannot primarily close the fascial defect, you have two choices. You can close the skin alone, or you can use a biologic mesh, and that's pretty much what many of us are recommending in the United States. This has really improved the business for the biologic mesh people. LifeCell was the first to really be up on this boom. It's been named among the fastest growing technology companies with, if any of you were smart enough to invest in their stocks, really, really good return within several years. And since then, there are about 8 to 10 other biologic meshes available, all with varying outcomes and, like Dr. Adrales mentioned, very little data to support their use. And it is very expensive. The average biologic mesh costs between $4 and $30 per square centimeter, which is many, many times more than in synthetic mesh. So there have been reports of up to $40,000 or $50,000 of biologic mesh being implanted in a patient to be able to bridge a fascial defect. That said, the recurrence is still very high. And a report out of Stanford and my current report from Pacific Coast Surgical this past year, in highly contaminated infected fields, you have about a 50% recurrence rate. Now that said, we're using the biologics in order to really be able to provide a moist biologic barrier as opposed to definitive hernia repair in order to deal with the primary infection. But the reality is, this is what Dr. Hannaford mentioned in the past, a very expensive hernia sac. So what's going on outside the United States? Really, biologic meshes have not become standard of care or even any part of care outside of the US. Certainly in Europe and Middle East and Asia, they're not using much biologics at all. And so what's happened to the synthetic mesh? What were we doing before the early 2000s? Were we using synthetic mesh, and why not continue using that in an infected field or a contaminated field? Well, if you ask the companies, they don't want you using it in any type of contaminated or infected field. Every single warning label mentions that you should not be using it in an infected field. Specifically, no contaminated surgical site, plus the mesh should not be used following a planned or accidental opening of the gastrointestinal tract. How many of you have placed synthetic mesh after having had an inadvertent enterotomy? Also, if you look at the FDA reports, most of the morbidity reported from synthetic mesh is related to some type of infection. So in short, really, using synthetic non-absorbable mesh has virtually no role in a truly infected field where you have soft tissue infection that requires extensive wound care. We're talking about acute infections, fistulas, abscesses, chronic infections. The only role where you would consider a synthetic mesh would be what we discussed earlier with Dr. Rosen, I believe, which was using synthetic absorbable mesh, such as Vicryl mesh, as a way to bridge a gap temporarily in order to prevent evisceration and coming back later. That said, even the use of that mesh, especially if you're unable to cover it with skin, has a very high risk of intracutaneous fistulas. So let's take it down one notch. let's not use it in truly infected fields. What about contaminated fields? Is there a role for synthetic mesh in contaminated fields? You have an open abdomen that's been open for weeks in a really sick patient, patient with a strangulated hernia. You're called in the middle of the night, you can't close the defect, or you had to do a bowel resection for whatever reason as part of the procedure. Should you put any type of synthetic mesh in that field? Well, there are certain surgeons that have gone on record that you should not use synthetic mesh in, let's say, strangulated hernia. You may have heard of these surgeons, Dr. Stopa, Lichtenstein, Nias, Reeves. They've all recommended that synthetic mesh should not be used in strangulated hernias. However, there's quite a bit of literature out there, granted small numbers, some prospective but none randomized, mostly anecdotal, which has successfully shown placement of polypropylene mesh specifically in open repairs after bowel resection. So this is a strangulated hernia that you reduced. You need to do a bowel resection due to gangrene. The patient did not have bowel perforation. That was an important point to note. And they never had peritonitis. So in the case of a unplanned bowel resection, the surgeons put in polypropylene mesh. And actually, the patients did fairly well. They may have had some wound complications. None of the reports show any need to actually remove the mesh. And there have been actually very few reports even of a mesh infection. Similarly, laparoscopic tap has been purported as a way of dealing with strangulated hernias, and successfully. There have been many reports of doing laparoscopic tap with or without bowel resection and placing mesh in the typical tap fashion, with no reports of need to remove the mesh or any infection of the synthetic mesh. Once again, not in the face of a bowel perforation and not in the face of peritonitis. Now, my practice is about 80 to 90% hernias, so I see all of the extremes. I see the mesh infections that were chronic, the ones with the patients that have chronic sinuses draining and treated on and off with antibiotics and incision and drainage for years, or patients with really chronic pain, with back pain or hip pain or chronic fatigue syndrome that get better once you remove that infected mesh. So if you ask me, should you put those in the contaminated fields, I say you should not, because I have this kind of distorted practice where I do see patients that are treated for either acute infections or chronic infections for years and years, and it dramatically affects their quality of life. Many of them have fistulas as a result of the infection and so on. But if you look at the literature, there are a lot of surgeons who claim have gotten away with putting in these meshes, and I don't know if those patients are just coming to see those of us who take care of these hernia complications, or if truly you can get away with it without a problem. What's at least interesting to note is, or good to note, is that you should be wary of what you're putting in, how you're putting it in, and how that affects your outcome. With respect to the mesh type, if you are going to put in a synthetic mesh in a contaminated or potentially contaminated field, I would recommend that you use a mesh that has the least inflammatory reaction, that it has the least foreign body load, and has the fastest ingrowth of its overlying tissue. So specifically, you want to choose a macroporous mesh. Macroporous, currently we define as having large pores of about 4 millimeters. But really, the important point is that you want to have the pores large enough for not only the bacteria to invade, but also your white blood cells to invade. So the microporous meshes, such as the EPTFE, tend to trap the bacteria without allowing the polymorphonuclear leukocytes to enter the pores. Also, the monofilaments are obviously better. We know that from sutures. Multifilamentous meshes have a higher incidence of infection and bowel obstructions and fistulas in some reports. And we now have lightweight mesh, which has a less of a foreign body load and less of an inflammatory reaction. And the inflammatory reactions really show encapsulation of the mesh, and that encapsulation allows for the bacteria to hide within this fluid collection, while fibroblasts and the angioblasts are pretty much inhibited from infiltrating the mesh and instead adhere to the outside of this encapsulated mesh. In terms of wound preparation, most of the surgeons that have reported putting in the polypropylene mesh took extra caution in terms of how they dealt with the wound itself. I know that using antibiotics as a lavage is very controversial. I personally do not believe in it, and there are many reports to support that. The antibiotics need a defined duration to come in contact with the pathogens, and just washing it for a couple seconds is not going to do that. That said, there is one pretty good study that shows that if you start immediately after your dissection with antibiotic lavage and continue doing antibiotic lavage intermittently throughout your procedure until the skin is sutured, in an animal model, it has shown that this type of lavage has been able to inhibit adhesion of bacteria to the surface of the mesh and also prevent their ingrowth. So that is one thing that I would use in your armamentarium if you do choose to place synthetic mesh in a contaminated field. And finally is IV antibiotics. We all give or many of us give perioperative antibiotics, but you should continue your IV antibiotics and make sure it's broad spectrum and continue it for a good 3 to 7 days post-operatively. If any of you have any interest in some of the articles that were listed on my study or on my paper, feel free to email me. Thank you very much.